Welcome to Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. It is Friday, April 19th, 2024, and today I am joined by Dr. Lubna Choudhury of Northwestern. Good afternoon, Lubna.
Good afternoon, Lisa. Thank you so much for having me in this podcast, and welcome to everyone who can join us today when we will be discussing family history, family screening, and genetic testing for patients with hypertrophic cardiomyopathy.
That is our theme of the month. It is an interesting concept as it has evolved since both you and I have been in this field. We started with pedigrees and family trees, and then we added on genetic testing, and now we're learning more about the meaning of many of these genetic markers. So let's dive in with a scenario. Patient comes to you with a new diagnosis. They're 45 years old. They've got a couple kids at home. They've got some siblings out and about, and their parents are still living. What do we think about when we think about a family, a multi-generational family, and the first patient getting diagnosed with HCM?
If you are that patient, imagine yourself coming to the office. What you will hear from your HCM specialist is that they will ask you details about your family history. And what does that detail entail? Well, your first degree relatives, by definition, are your children, your parents, and your siblings. So you're going to be asked about health details on all of them, especially heart disease history. If they have any devices, if they have devices, did the devices ever go off appropriately? That's an important thing to remember. And also of the people in your family who may have dropped dead suddenly, if there are any. That's a very important piece of family history. We ask because we are trying to gauge, remember, your risk of bad things happening after we look at your family history. So you will be giving us a 3-generation family history.
Let's pause there for a second, because in all of the time that I've spent on the phones talking to lovely people with HCM all over the world, when you ask about family history, things can get a little blurry. And I have found oftentimes people believe the first person who told them what happened to their loved one. They had a stroke. They had a heart attack. They might have had an aneurysm. And this often comes from the paramedic, not an autopsy, not a clinical person who's really evaluated the case. It's the first thing you hear, and it sticks because it's emotional. And years later, when you think back, what did happen to Uncle John or Aunt Sue? You remember the myth, but it's really important to try to get the fact. Where do you think is the best source to try to get to fact from myth?
There are certain things that kind of raise our antenna as to your loved one who has died suddenly. First of all, were they young when they died? Were they below the age of 45 or 50? They drop dead and say, Uncle Joe suddenly had a heart attack in his sleep and he was 35. That's not a credible diagnosis for a cardiology professional because, that's much more likely to have been an HCM-related death. If you fortunately have somebody, and we will ask it, who in your family has access to the autopsy if Uncle Joe had an autopsy? And if they do have that autopsy, can you get me a copy? And I am well known for asking patients to give me autopsies of their loved ones who have died. And I have got a huge collection of autopsies that way.
Totally.
My patients are very diligent in unearthing the autopsy reports and that are unbelievably useful. Let me give you an example. I have a 40-year-old woman who comes to me and, she says, my father died whitewater rafting. He was in his 50s and they did an autopsy and they found HCM. He was short of breath for a while. And, I'm here. And so she's here with a mild heart muscle thickness, a mild phenotype. So I ask her for her dad's autopsy, and I find out that he had a huge dilated heart with wall thickness, which was increased, and he had tons of scar in his heart muscle. So his phenotype looks very different to my patient's phenotype. My patient's heart is mildly thickened. She's very functional, asymptomatic, no obstruction, nothing. And her MRI shows virtually no scar, very little. So I tell her that, look, I have your dad's autopsy in front of me. I have your heart muscle data. I have your MRI in front of me. And so I can see the two hearts and how different they are. And therefore, I don't feel strongly, in the absence of any rhythm abnormalities that you have, that you should get a defibrillator. In the old days, days, we would have said, your dad had sudden death with HCM, off you
You get a
go,
device.
defibrillator, no further discussion. But, now we have learned to be nuanced about defibrillators because we have the means to compare your heart, how it looks, to what your loved one's heart looks. And sometimes it's not just autopsy. I would ask them, if you don't have an autopsy, can you get me an echocardiogram that was done of your loved one before they died? So that would give me some clue. We try to unearth family history and try to get at what exactly your loved one who has died actually had.
When we do our intake and navigation calls here at the HCMA, I do ask some weird questions and I'm like, I'm sorry, I'm going to ask questions in a different way. So you said your loved one died this way, or that they didn't have a diagnosis, but they had stroked multiple times. So stroke is connected to AFib, which is connected to HCM. So we look at them a little differently. And all of the data about your family, it doesn't predict where you're going to go, but it gives us an idea of what your family genetics are capable of doing. And it gives the clinician enough information to start to help make decisions. And this is that shared decision-making piece. And when we're relying on information from our loved ones who have passed or our loved ones that are still here, we're looking to see what we can learn from their experience that might help shed light on what might be an option for us. And it's really helpful to get a good family history.
Yes, I cannot deny that. That's absolutely crucial. And, to say two things, if you have HCM in your family, it's the same gene that's causing HCM, right, in your family. However, it's important to remember that no two patients are exactly alike, and the same gene can make very different manifestations of HCM. So make your heart look very different from your loved one. And if you have somebody who has passed, whose autopsy report you're showing me, and I see that they had pretty mild thickness, but they had quite a bit of scar and they died suddenly, and I'm looking at your MRI, you have pretty mild thickness, you have quite a bit of scar, but even with that mild thickness, I'm going to recommend that you may be at increased risk of sudden death, so you should be protected by a defibrillator. So see how it works. It really, your loved one's data, the family history, their heart pictures, their heart images or autopsy reports really help us frame what we should be recommending to you.
And that is old school use of family history and how we can use the old school methods, meaning no genetic data, to help tease out the family tree. So back in about 2005, the first clinically available genetic test for HCM was put on the market. Company doesn't exist anymore. It was Coreligen. It was sold to LabCorp. God only knows where the testing platform is today for them. But lots of other people have come up. Invitae, GeneDx, Ambry, and more have come and gone. But the concept of next generation sequencing has pretty much been used by all of the companies that are out there now. And we're able to identify approximately 40% of those with a genetic mutation that has already been connected to HCM. Who do you think should get genetic testing, and in what order in the family should genetic testing be utilized?
So we offer genetic testing to pretty much 100% of our patients, unless they really have no living relatives anymore. If you have children, we'd definitely recommend genetic testing. If you have no children yourself, but you have a bunch of siblings and nieces and nephews, I think genetic testing is useful. So those are kind of very common scenarios where we recommend genetic testing. But from Lisa's point, now we have platforms with huge sequencing abilities. They test a bunch of different genes. So we pay for that, wide net that we cast to pick up your pathogenic variant, which means that the gene mutation that's causing your HCM. So we pick that up at the cost of picking up a lot of cockles and mussels and not the big fish. Right. The cockles and mussels are really the variants of uncertain significance that we pick up. Many times they're not relevant. Sometimes they are pathogenic variants of recessive conditions, which we have a genetic cardiology team in Northwestern where we,
a pretty good one too.
Yeah. And, with Dr. McNally, Dr. Wilsbacher, et cetera, they're the ones who most frequently see my patients. So when I see an array of different things like that, I send you to them to have further interpretation and dig in deeper to see whether you should be tested. And so we have found some other conditions as a result of these wide gene panels that we use these days. So you have to keep that in mind. But as Lisa said, up to 40% of you will show up with the pathogenic variant. And that's bingo, because now we have your variant and you have 4 kids. So all of them can be tested for the same variant. All of them could have it. None of them could have it. It's a 50-50 for each person, right? The 50-50 inheritance. So that's where the concept of cascade family screening comes in. So we cascade it. So from parent to child, there's a 50% risk. From child to grandchild, 50% risk. So your grandchildren are not going to have HCM if your child doesn't have it.
Right.
See? So that's kind of the way it goes.
Sometimes I will see in the community a physician think, well, this person might have HCM because I see their heart's a little bit thick. So I'm going to screen this individual who I'm not sure about yet and clear or give you a diagnosis. I think this is a dangerous path because 60% will be gene negative, best case scenario, and you can miss that individual out there from the community screen. So I think it's really important that you're working with a multidisciplinary team that understands the nuances of HCM to define the definition of disease first and then move on to genetic testing.
That's really crucial because, sometimes I'll tell you what I do, genetics, now we have such advanced imaging technology that we can pick up disease at a very early stage. Okay. So HCM, say a 30-year-old comes to me with a heart muscle thickness of 1.3 centimeters. And that's really not diagnostic by the books for HCM unless they had a family history. So sometimes I tell people to come back to me in a year. We'll repeat your imaging. And, we have to repeat imaging for a few years in a row until they actually reach the present diagnostic criteria for HCM. So you have to be patient. I'm not going to tell you and label you with a diagnosis of HCM if you don't meet criteria for it. So you have to be patient, be willing to come back, get another MRI, and then we can talk. And so I have done that to a bunch of patients, and we have determined some have athlete's heart, they have reduced their exercise, LVH went away, their wall thickness became normal. So what if I had labeled them as HCM early on? So I am patient, and I want you to be patient.
Be patient, patients, please. That works. I can remember a couple of unique cases that I've referred over to Northwestern, one of which was a woman early on in our understanding of Fabry's disease. And she ended up having a GLA mutation, which is not what we typically see in HCM. It's what we call one of the mimickers. So genetic testing certainly has a benefit here to identify which kind of thick heart do you have. So I know everybody thinks about HCMA as just hypertrophic cardiomyopathy, but we really serve the spectrum disorder community. So all thick hearts are not sarcomeric mutation HCM. Some are Fabry's disease, some are amyloidosis, some are uncontrolled hypertension. Some may have other genetic causes like LAMP2 or some of the RASopathies that these kids have, syndromes and thick hearts. So knowing the family history, understanding the presentation, really important. So I also sent you another guy who ended up, I believe, having sarcoidosis.
Yeah, he was having ventricular tachycardia right, left, and center, as well as atrial arrhythmias. I looked at his ECG first and I said, your ECG doesn't look typical of HCM, so I'm going to do some more digging. And he had a PET CT stress test and he ended up having sarcoidosis, treated with steroids, doing fine. So it is very important to get the diagnosis right. So I think that's where the centers of excellence come in, because if you are in a community cardiology practice where the cardiologist sees many more patients than we see as an individual in Northwestern. They're very busy people. They may not have time to go through all the different tests we need to do to be certain that you have HCM. Because, one of my jobs as an HCM specialist is to know when it's not HCM so that I can refer you to the right person to get treated right, and these conditions that Lisa mentioned, these are HCM mimics, so to speak, and they can look just like HCM. You could have cardiac amyloidosis that looks just like HCM. You can have ventricular arrhythmias, but their treatment is totally different. So it's so important to get the diagnosis right. Genetics can help us a lot, because when we started with Correlagen, I am of that era, and I was telling them that in your genetic testing panel, you got to have these HCM mimic genes tested for so that we can rule them out. And the transthyretin gene got in there, the GLA gene got in there, because we had conversations, I remember, with that company. And then subsequent companies, incorporated those genes. And so there you are, bingo. Another patient sent to me with HCM. She's very symptomatic. And then I find out that she has cardiac amyloid. Did the genetic testing, she had TTR amyloid, and her heart looks just like HCM. So not all thick hearts are the same condition.
And that is why you will see new terminology being used by HCMA, that we are the home of the big hearted. So yes, we primarily will continue to address the needs of the hypertrophic cardiomyopathy community specifically, but more generally, we got to open the doors a little bit wider, get all those thick hearts in here to good centers who can do the differential diagnosis and ensure that we're treating the right patient with the right therapies at the right time. These are not inexpensive therapies for the most part. They're very specific. So you don't want to give somebody a drug that's really, really expensive. They don't need it. And there are so many great therapies now for amyloidosis, for Fabry's disease, and for HCM. Knowing which bucket you fall in is critically important. So we can use genetic testing to look for the index patient in the family. And then this is where things get a little crazy with, just trying to figure out the laws and the logistics. So the Genetic Information Non-Discrimination Act provides protection for those who get genetic testing, but I don't carry a diagnosis already. So if you have HCM, you're diagnosed with HCM, you get the gene, you got the gene. The insurance companies have already marked you as you have a disease. So life insurance and long-term disability insurance, they're going to rate your premiums. But we wanted to make sure that people who don't have overt disease have the opportunity to find out their genetic status and protect them a little bit. So what we can protect them from is discrimination related to their employment, their access to health insurance, and their access to educational opportunities. Your genetic information cannot be used against you in any of those formats. However, life insurance and long-term disability insurance companies can rate your policy based on your genetic information. And on the converse, if you prove you do not have a gene that runs in your family, you can present that to the insurance company for lower rates. So I like to always talk about Gina. I was there banging fists in Washington back in 2008 when it finally came through. Sharon Terry, good job at the Genetic Alliance leading that cause. But it's a little complicated. So it's important that people understand what they're doing when they go ahead and get these tests.
Yes.
So you have genetic counselors available at Northwestern that can help people walk through these processes. A lot of different centers have gene counselors and counselors. Some don't. So there are services if your program does not provide one, we can point you to a program that can provide that. Is there anything else you think people should be aware of before they consent to genetic testing?
It should be spelled out to them what the possibilities are. And I tell them that there are 3 kinds of results when you do genetic testing. One is bingo, we found your pathogenic variant, which is the mutation that caused your disease. 2 is we found nothing. We didn't find a genetic test. That doesn't mean you don't have HCM, though. It means that we haven't found your particular genetic change that caused your heart muscle to thicken, because that's a limitation of our testing. And the third possibility is we found the cockles and mussels. As I said, we didn't find the big fish, but we caught variants of uncertain significance. And they're just that. That means we don't know what they mean. We can't use it to test your children or your siblings or your family because we don't know what they mean. However, I have a family that's, comes to mind where a variant was reported as uncertain significance. There were 5 siblings in the family. We tested all of them. 4 of them had it with the disease. Okay. So then this variant now is classified as significant because it tracks with the disease. Okay. So that's how you resolve a variant of uncertain significance. If you see it in enough people in the family who also have the thickened heart muscle, then this gene becomes significant. So, yes, I have seen that.
We recommend that at every annual appointment with your HCM specialist, you inquire, has anything new been learned about my genetic test results? Because there are changes. One of our own staff members had one of these changes where the genetic testing was done 6-7 years ago and no mutation identified or a VUS was found. And now, ta-da, that VUS actually means something. And then we could use it to test the rest of the family.
Yeah.
So we are continually evolving. If anybody thinks we're at the end of this game yet, nope. Stay tuned, more chapters to come. We're still learning. And we know what the core mutations are, but there could be other players on the back end that are kind of modifier genes that could be leading to different things happening in a person. We don't understand them all yet, but we're getting deeper, we're getting better. We've been in talks with a company who does full genome sequencing, and it's actually kind of interesting. And stay tuned. I might be in lifetime getting my own results or at least recording them and sharing them with you later. It's an evolving science. Let's take another scenario. We find a genetic mutation, and let's just say myosin binding protein C, 2024. We have one company in the market already who has provided genetic therapy to 2 individuals. One started in October, the other one was I think January. So we have 2 people who've been dosed with a genetic potential correction of the abnormal protein inside of the heart causing the problems. And there's another company coming to market end of this year. And then there are other companies who are developing other target genes such as troponin I, EAG gene, and some of the other mimicker genes. What do you think about the dawn of genetic therapy in hypertrophic cardiomyopathy? Tough topic.
Yeah, it is a very exciting, futuristic possibility right now, but it really is only a possibility right now because genetic therapy, gene therapy as it's called, is, you have to tread very carefully because we have had experiences in other disease states where, not HCM, where things did go wrong. So we are very careful about doing gene therapy trials. And, the companies have, kudos to them, have taken care that they're not rushing into this headlong, without taking due process and due care. And I think if it pans out, that's the question. If it pans out, we are really waiting for these results. These are really phase 1 studies. And if it really pans out, then it would be very exciting that, the gene defect, what does it do? In most cases, it's haploinsufficiency. That means that you don't have enough protein that the gene makes to make your heart work normally. So the gene therapy delivers that protein, the MYBPC3 gene that's being trialed now. That's exactly what it does. So we want to know what the results are of these preliminary investigations first. Then that would inform us how to design more robust trials in the future with gene therapy to see, what's happening to patients with this. I, have patients, who would fit the criteria of these gene therapy trials. But, we also have a committee where we meet and we look at this and see. The bottom line is we want to do the best for our patients. So we're going to leave no stone unturned to be careful about this. That's the bottom line.
So I will add 2 comments to that, and then we're going to take a slight pivot to talk about something else. A couple of people have approached me saying, I don't want to do anything else for my HCM until this gene therapy thing is real, and then I'll do that. I think that's a dangerous approach. If you have HCM today and you're dealing with symptoms and you need to take treatment for that symptom, do not delay your therapy for the hope of something that's not been proven yet. Correct. It is hopeful, but it is not proven. It's just a trial. We call them trials for a reason. because we got to try and we got to see. And we're all going to learn together. That is definitely point one. Don't wait for the future. Do what you need to do now. Keep an eye on the future. The other thing I will say is the piece we kind of glossed over a little bit while talking about all this, what's in the family. There is an emotional component to knowing your family genetics and to understanding what happened before you and what might happen after you. I would encourage those who are listening to take a moment to really process what knowing your genetics means to you. It doesn't have to be a bad thing, but it is something that needs to be processed. I found out my genetic mutation in 2002, the beginning of 2002. I also learned that I gave the gene to my daughter at the same time. She was 7 at the time. I was a bit devastated that I gave her the gene that I had, but my dad had already given me the disease, and he knew that he gave me the disease in terms of genetic giving, and he felt bad about that. I refer to this as genetic guilt. We all get a little genetic guilt from time to time. It's a place to visit, but don't live there because you didn't mean it. It wasn't something that you did to be mean or bad or not because you love somebody. It's just biology. Don't overthink the biology. You now have options that no other generation before has had with this disease. So if your child, your sibling, or you find out that your parent has it, there's just emotions that go into processing all of this. But you're as much to blame or to take credit for the HCM as you are for their personality, their smile, their eyes, their wit, their intellect. Go easy on your own genetic guilt. It doesn't solve any problems. It just creates other ones. So process it.
And I tell people that if you have HCM, if your child gets HCM, it's not the end of the world. It's not, one of those devastating genetic diseases that, cause destruction of your child in the womb or, have your child die on you when they're a few weeks old. HCM is compatible with a normal lifespan in most people, and there's a lot we can do for you. So this is certainly not something that's a death sentence. So that should lessen your guilt.
You should talk as a family. We have resources. If you don't know how to start the conversation with your family, we have ways that we can help you. You can go to our website. We have our patient journal, which has a really easily laid out schematic that you can even just take pictures and text it right to your family member and say, this is what's going on. In the event that you have somebody in the family that you need to talk to and discuss, we can be a resource for you to share that information. And our new HCM Nest service, which sends information to educate patients about different aspects of HCM. We are soon going to be adding an element that you can share that information with your family member. The next thing I'm going to pivot to, it's about our next podcast today, which is about the 2-year anniversary of mavacamten hitting the market as Camzyos. I'm curious to hear what your 2-year experience has been with a new tool in the toolbox.
I think by and large, it's been a great option for many patients who are not yet at the point where they want surgery or need surgery, or they're quite symptomatic. It has helped in many, many ways. So let me give you some ways. So for example, if you have uncontrolled blood pressure, the metoprolol, which was the workhorse drug for HCM, is not a great blood pressure drug, right? So in order to control your blood pressure properly, we need vasodilators, we need diuretics, and we can't really give you those if you have really obstructive HCM, and that's causing symptoms of shortness of breath, chest pain, lightheadedness, what have you. Mavacamten, the Camzyos that has been approved, has been a great boon to this group of patients because we can reduce their obstruction or even abolish it in many cases. And then we can give them vasodilators for their blood pressure. And the blood pressure is well controlled. They're very happy. Everything is going great. So we definitely have that in our experience so far. But I have also learned how to use this drug in more nuanced situations. For example, we know that if you develop atrial fibrillation while you're taking the drug, mavacamten, you're more likely to drop your pumping function of the heart, your systolic function. So your ejection fraction may drop. So my practice is, if I find that one of my patients has AFib, I would hold the mavacamten. It has a long half-life, so it doesn't leave your system completely right away. And then once we got control of the AFib or restored normal rhythm, you're back on the mavacamten. That's a prudent way to use it, in my opinion, because I avoid these patients then coming to me with a drop in their systolic function and, God forbid, having shortness of breath because of heart failure with systolic dysfunction. So that's one thing. Another scenario is when people have acute pericarditis, which can cause atrial fibrillation, or myocarditis for that matter. Those are patients, or acute intercurrent infection like influenza, which is very common. So all of you, by the way, should be vaccinated for flu every year.
And COVID
goes. So if you have an intercurrent illness, like a viral illness, I think mavacamten should be held, because I've had the experience, again, people dropping their ejection fraction while continuing to take mavacamten during that time. So these are cautionary tales with the drug, and you just need to be getting it from a place where the physician has experience with dealing with these kind of conditions. So I see enough patients to know what could happen with mavacamten. And the other thing, I'm very strict with my patients, that if you're going to take mavacamten, you have to moderate your alcohol consumption. You cannot be a big drinker and ask for mavacamten from me. I'm not going to give it to you, because that is exactly what happened to one of my patients. Didn't listen to me, dropped his EF. Okay, so these are practical things that I'm going to be talking about.
I think it takes a while to learn real world, right? It's been out there for 2 years. And if you want to join us in another hour or so, we're going to do a full podcast with Matt Martinez and Angeli Owens on the 2-year anniversary. So we're going to take a deeper dive into what the numbers look like. So that's my hook to come back and join us for more podcasting from the HCMA later on today. We're going to talk about that, but learning how to operationalize, how to get the pre-authorization, how to get all the echoes done, how to make sure that the patient is being safe in the home environment, not using too much alcohol, communicating when they have a virus or they're sick. This is something that is kind of new to us as patients. Like, what do I communicate? When do I communicate? How do I communicate? What's important for you to know? And as we're learning more about myosin inhibitors in general and Camzyos specifically, I think we're all going to learn. And we've been sharing every time we go to meetings. Like, it's been cool over the past 2 years. It's like, what have you learned? What have you seen? And it's real world, tactile. Here's an N of 1. Here's an N of 1. Let's figure out, oh, we're seeing a trend with the flu. This is how we should handle it. Alcohol consumption, not a great idea. There's lots of different things that have come up, and some of them are a little bit more complicated. Pregnancy on Camzyos. It has happened, and we're waiting on some more information on that. But if you do get pregnant while on Camzyos, it is recommended at this time that you stop the drug and that you seek advice as to how to handle the pregnancy going forward. Depends on how far along you were before you realize and stop the Camzyos, because we don't know how a myosin inhibitor impacts a fetal development of a heart. We don't know. So we're learning. What else have you learned?
I have learned actually from my patients the following, that many younger patients, and I'll be quite candid with you, really don't like the idea of being on a lifelong drug. Okay. And the patient community can attest to that. My younger patients will say, okay, send me to surgery, one and done, I'm done. If you have a great surgeon in your institution, that is exactly what I do. Because, I don't know the data on Camzyos for 10 years or 14 years or 15 years. So I don't know. Young people move, right? They change jobs, right? Their insurance changes. So what's going to happen to the reimbursement for Camzyos and coverage of Camzyos? I have to think of that too. You don't want to bankrupt your patients,
No,
so I think of all those things. So for younger patients, my recommendation usually is to get surgery.
And I have a number of people who have opted to go for surgery or alcohol ablation or mitral clip, all kinds of interesting things to get rid of obstruction. And or some have chosen to wait for next in class or second generation. Let's learn more about it. All of these are interesting ideas. And this comes down to shared decision making. So it's really important that the patients educate themselves to the highest level possible. It's not bypass surgery and you're done and you need a statin. This is very complex surgery. Alcohol ablation is very complicated as well. It has to be done in high volume centers. And again, I say this almost every podcast. The concept of center of excellence care matters. You're not all the candidate for the same thing. This is a very complicated disease state. I wish we picked a better disease to have that was easier, like extra long second toe syndrome, and we just shorten our second toe. I don't know, but we don't. We have HCM that has a lot of different aspects to the cardiac functioning, whether it be the arrhythmia burden, the pump function, the scarring, the interplay between our atria and our ventricle. We're complicated.
Yeah, and it comes with concomitant heart disease. Don't forget, we see a lot of complicated HCMs here at Northwestern. We see people who have multiple valve diseases with HCM. Aortic stenosis, for example, very common, coexists with HCM, not so common, but they can coexist. And then your whole management and treatment will really depend on identifying all the things that are wrong with your heart that you need to fix. And that needs some time and care and some, detailed testing and diving into.
Completely understood. Any last thoughts on the first 2 years of a myosin inhibitor in your clinic?
I think it's a very exciting time, and I'm very glad we have an option for patients. This is the important thing now, is to understand where it fits in to a patient's treatment algorithm. And no two patients are quite alike with HCM. We have to tailor treatment to everyone individually between, what the patient needs, wants, and what we think they should have. So we need to give the patient full information so they can make a decision. We can help them make a decision. Sometimes they ask us, what would you do if I were your brother? And then I tell them what I would do. But, so it's a back and forth between the patient and the clinician. But we have a tool now, an extra drug, which is a designer drug. That's the way I would pitch it to patients. It's a designer drug designed to do something very specific for your disease. And it's very effective, but it needs to be used properly by people who have experience and who are not going to put you on it if you actually have an HCM mimic, because then you're going to be in big trouble.
We have some questions coming from Facebook, which we'll get to in a minute, but you just brought up a great point, so I want to dive onto it. So we started talking about genetics and understanding which bucket are you in. There is the possibility to be more than one. We do have people who have genetic HCM and genetic amyloid together. They need a very special type of management, but they're ultra rare. But if you have amyloid and not HCM and somebody tries to put you on a myosin inhibitor, this is not going to bode well for anybody. This is going to be bad. So we need to make sure that you have the proper diagnosis, which again, out of the community, and I always point out my window when I'm like out there in the wild world, a lot of clinicians don't really understand how to make that differential diagnosis between HCM, amyloid, Fabry's, even some of the Danon disease hearts can be confusing to figure out what they are. So these are the mimickers. So really important that you get your good diagnosis. Even if you're not going to be able to go to an HCM center of excellence for every visit, go and confirm your diagnosis. If you are low income and you need assistance, the HCMA has the Lori Fund, and we will provide up to $600 in travel funds to ensure that you can get to a center. So if you're not sure and you don't know how to go about this, call the office, 973-983-7429. Call us up. We will help you get through the process. Dr. Choudhury, does a myectomy grow back after time?
I would say no, 99.999%. But I'll tell you what, I have seen patients who have had myectomies elsewhere. The hospital shall remain nameless. That patient came to me with obstruction. And what I discovered is that the myectomy was done in the wrong place in the heart. So they did not address the thickest part of the heart, which was participating in the obstruction. And they went down further and then shaved off the muscle. So if you have a surgery like that, you're not going to expect a good result. And that's exactly what happens. But growing back, I have not heard. Very rare.
It's a great point to talk about properly completed myectomies. Again, high volume matters, high volume matters. And if you didn't get it the first 2 times, high volume matters. So if you have somebody who doesn't do a complete myectomy, that may not lead you where you want to be. I have seen a phenomena that has occurred a few times. It's not real common, but because of the geometry of the heart being shifted by removing some of the muscle, the heart can start to kind of pump a little bit differently, and obstruction has occurred in a different part of the heart. I've seen that maybe 10, 20 times in 25 years, but the heart just re-obstructed from a different mechanism at a different point in the heart. Rare, ultra rare.
So let me talk about that. This is not, I have seen it quite a few times that after a myectomy, if there is residual obstruction, as we call it, the usual mechanism for that is chordal SAM. So in other words, the surgeon went in, did the myectomy in the right place, but didn't bother to move the cords out of the way, reposition the papillary muscle, and do a papillary muscle repositioning operation. And, if you have a thinking surgeon who is experienced in operating in HCM patients, they would know how to do that. And, when I read an MRI on my patient, I write in my observations note, there is a redundant chordal apparatus so that the surgeon knows that you need to pay attention to that chordal apparatus because that's going to come back to bite you. So that's the most common mechanism, how the gut obstruction happens. But in my experience, it's not usually a whole lot of obstruction. It's definitely better than what it was, but that's the most common mechanism because the surgeon didn't do a full job, so to speak.
Awesome point. I think we talk about myectomy, cut muscle, and it sounds simple, but it is not. Papillary muscles are something that most people don't stop and think, hey, I have papillary muscles inside of my ventricle. But you do. Everybody does. They look like little fingers and they help your mitral valve open and close. But if they're pulling the valve in the wrong direction, we have a problem. And those papillary muscles need to be tethered or repositioned. There's a lot of different things that the surgeon can do. So being able to evaluate that papillary muscle anatomy and knowing what to do before you go in is really important. And I think some people with papillary muscle driven obstruction, they're angled wrong. I don't think they do as well on myosin inhibitors because no matter how much you try to help the muscle, the valve is getting pulled into the outflow tract because that's where the muscle's telling it to go. There's another question from Wendy is like, if it does regrow, are they candidates for medication? So Wendy, I'm going to turn your question around a little bit. If your papillary muscles are the driving force, surgery is your option. If after surgery you're still symptomatic, there are clinical trials underway right now for mavacamten in the non-obstructed. And we're doing those same studies in the aficamten trial. And there's going to be another trial after that for another myosin inhibitor. I do believe that there will be a role for the non-obstructed patients with myosin inhibitors in the future, but we need to see what that patient profile is. We need to do the studies. We need all of the community to participate in clinical trials when they're available. And we're going to need a lot of people for a lot of trials over the next couple of years because this is our time to shine. And this is our time to see who can be benefiting the most from these new agents.
Again, going back to our original theme, you will be asked many questions about your family history, and you need to be able to provide as much data as you can to us, which helps us take care of you. And, you need to come to centers of excellence, which can offer you clinical trials as one of the ways in which we can help you. When I'm seeing patients in clinic, what's going on in my head is, okay, he's on all these treatments. What else can I offer him? Which clinical trial would we fit into? And then I would offer it to you. So that's not a luxury that many cardiologists in the community have, but we in large centers do have that luxury. So do seek us out because we may be able to help you.
Well, we know that we helped Wendy today and she thanks us. So there's a little thank you from Wendy for answering her questions. I'm going to give a couple of awareness and event notes. May 4th, we will be in Cincinnati. So may the 4th be with you and maybe you be with us on the 4th in Cincinnati for a Big Hearted Warrior tour with Christ Hospital. So we'll be out there. Hope to see many of you come on out and join us and learn more about HCM. I want to also acknowledge that we have the other webinar coming up later today. So please join us for that. And we have a lot of content coming up in the next couple of months. We have more podcasts, more stories, more webinars, lots going on here at the HCMA. And a lot of clinical trials are going to start opening up very, very soon. Some new concepts, some old ones coming back. Imbria had a good readout. We're going to go into a phase 3. There's going to be more recruitment for the cytokinetics trial. I'm heading to Lisbon Portugal to hear the updated information on cytokinetics and their new agent. And we're really looking forward to seeing that data in Lisbon. I might even stream it live while it happens. And that's all I've got going on here right now. Dr. Choudhury, I thank you so much for your time today. I know I got to stop in and see you last week while I was in Chicago, and we have some wonderful projects that hopefully we'll be able to bring to the people of Chicago very soon with you and all of your wonderful colleagues.
Thank you, Lisa. Really appreciate being part of this.
Thanks for everybody for joining.